there have been many instances of happenings in our community, in the world, as it relates to negativity and negative news. But every now and then, we have an opportunity to present information that's good news, that's positive news. And I can't think of anything that's more important than news about health and medicine and living well and not having to go through a whole lot of things that our foreparents and people had to go through years and years ago. I'm more than a little happy today to be engaging in a conversation about a medical or treatment that in fact has affected thousands, literally hundreds of thousands of women down through the years. And it had to do with fibroids and fibroids tumors. This is a call to action.
A call to action.
I'm your host, Alex Haverchamp. She remembered that he came on just a little late, but we still got him in. and I have with me today Dr. Tariq Patel and Miss Pamela Brown. And we're going to talk about fibroid tumors and, some of the things related to them, how to treat them. As a matter of fact, Miss Pamela has experienced this procedure that Dr. Patel is going to talk about. And the objective is to, and there's some good news, potentially, as it relates to fibroid tumors that we will be talking about. So let's talk about what is a fibroid tumor.
A fibroid tumor is a mass that you see in the uterus that occupies space within the uterus and can cause various symptoms. It can cause symptoms such as heavy, really painful bleeding between periods, and because it occupies a space within the pelvis, it pushes things in the pelvis. It can push on your urinary bladder, causing incontinence. It can push on your rectum, causing constipation, and just a slew of other symptoms that you may feel.
Okay. And traditionally, the way to address it is through surgery?
Traditionally, people have done surgery to treat uterine fibroids.
Okay.
There are various other treatment options, of which today we're going to talk about one, which is uterine fibroid embolization. Okay. But surgery has traditionally been the way to treat this.
And it's my understanding that, that one of the former approaches to dealing with fibroids would be the removal of the uterus. Is that?
Yes, hysterectomy has been.
It's called a hysterectomy. Although I've never had one.
Yeah, I imagine not.
But I've had, I've had people to talk about them, and I think that in some instances, fibroid tumors traditionally must have been pretty serious, because when people engage in hysterectomies, then that means that they no longer can get pregnant, right?
That's correct. Hysterectomy is when you take out the entire uterus. It's a very invasive procedure where you open up the belly and you take the entire uterus out. So women no longer have their uterus and can no longer have children.
Okay, so they can't have a baby. So talk a little bit about the process. Now, before we do that, let's introduce Miss Pam. Miss Pam, I understand that because of your being so pleased with the procedure that you went through as it relates to having fibroid tumors, that you are willing, and we really appreciate your coming on, because, it will help assist other women, who are going through the same problem. So just as a citizen and as one who's concerned about the community, I want to thank you for coming on and sharing your story. So talk about your situation with the tumor.
Well, as Dr. Patel had stated, I had issues with irregular menstrual cycle, constantly having problems as far as urinary, because it does pushes on your bladder, where you have constantly, urinary issues as far as that. And also it does cause some discomfort too. So it was something that I had to check into to find out what was going on, because I wasn't sure what was happening because of the heavy menstrual cycles that I was having.
And so you went to the doctor?
Yes.
And then, so what happened?
I went to the doctor. At first, I was presented with the hysterectomy, and somehow I wasn't comfortable with doing it, so I was referred to Dr. Patel, and he explained the UFE to me as far as what it entailed, and I thought it was a good thing for me. I felt more comfortable with it than having the hysterectomy done.
So you did go through the process?
Yes.
Did it help?
Yes. Very happy with it.
Yeah, okay. So what changes did that procedure result in, Doctor? Talk about how you did it and what changes it actually produced. Now, had you already had children?
Yes.
You okay? But you still did not want your uterus removed.
Right.
Okay.
So many women that come in have already had children and don't want to have children moving forward, but
Okay.
they feel the need to keep their uterus or the desire to keep their uterus.
Right.
So something that I frequently hear is I came into this world with my uterus and I want to leave this world with my uterus. So, I hear that and I can't
Baby or not,
but I do understand that. Right. And so having children is sort of a secondary conversation. It's more about whether they want to preserve their uterus or not.
Okay.
And so many women want to come in and they want to have something outside of surgery done. So someone that would be a good candidate for this procedure is someone that has symptomatic uterine fibroids, because fibroids are very prevalent. They're more prevalent in the African American population, but they're prevalent across the board in all populations, anywhere from 25 to 45 to 50. Many women have uterine fibroids. So, and it's actually underdiagnosed because the symptoms are so vague. So you have some of these vague symptoms, you go to the doctor, you get an ultrasound or some other imaging study that shows fibroids, and the first thing that many women are presented is, okay, let's take your uterus out. But your symptoms are kind of vague, so you feel like, well, should I just hang on or should I really get my whole uterus taken out? It seems like a big jump for the vague symptoms that you may have. So this is really sort of a nice intermediary thing that we provide. It's a very minimally invasive procedure, very well tolerated, and you get to keep your uterus. So it's not such a big jump for what seems like vague, constant symptoms.
Okay. Now, when you said minimally invasive, so actually what does that procedure entail when that means you don't do like they used to do a long time ago. So the scalpel,
so with no big knives or swords or anything like that. So it's minimally invasive. So it's very similar to what cardiologists do. What we do is we use X-rays, ultrasounds, and various imaging modalities to guide our procedures with a great deal of precision. So for this procedure, what we do is we put a small catheter, which is just a flimsy little tube, into the artery here in the groin. And as we're looking under X-rays, we guide that catheter into the two major arteries that are giving blood flow to these fibroids. And we can see where those arteries are as we inject dye through that little flimsy tube. Once we get to those arteries, we inject little beads, really, really small beads, and those beads coalesce together and they block that artery. We do that on both sides. So now that fibroid is no longer getting blood. If it doesn't get blood, it can't get oxygen and nutrients that it needs to stay alive.
So you choke the fibroid.
So we choke it, right. And so it doesn't get blood, so over time it shrinks. So we pull the catheter out, about 45 minutes of a procedure, you go home with a little Band-Aid here in the groin. So no major incision, cuts, or wounds. You go home literally with a small Band-Aid here in the groin where we put the catheter, and that's it. Okay,
talk a little bit more, Doc, about signals or signs. I know you kind of mentioned it, but that a female can have that may indicate that she may have fibroid tumors. I think you said you had the heavy, but there are other factors?
Mm-hmm. Urine frequently.
Okay.
That was an issue.
Yeah,
and had you can feel the heaviness of it too as well.
Yeah. Thank you. What about, because what we want to do, Dr. Tariq Patel, did I do that?
You got it right.
Yes, we want to impart information, so just doing the regular course of things, that, that we can create a conscientiousness on the part of females that, well, hey, I see these signs, so maybe I should get checked. And then also talk about, how should one get checked? Do they go to OBGYN, or just how does that procedure work? But talk first about the signs.
Sure. So the signs and symptoms of uterine fibroids, they vary tremendously, but the things that we hear frequently are very, very heavy periods.
Okay.
Passing large clots during your period.
Okay.
Anemia, just a sense of overall fatigue because you lose so much blood during your period that your blood counts go down.
Right.
Bulk symptoms, which are because this mass is occupying space in your pelvis, as I said, it pushes things around. So you can have constipation and urinary frequency and incontinence. So if you're having to rush to the bathroom and you go, and then 15 minutes later you feel like you didn't completely empty, that is not normal. Having to wake up twice in the middle of the night to urinate is not normal. These are things that we frequently hear. So if you have any of those things, you should certainly go get checked out to see if there's something in the pelvis that's pushing things around, causing it.
Now, what's the procedure for checking out? I mean, how do you do it? And then talk also about, the age range. I mean, is there any kind of age range where one is most susceptible to having fibroids? And I guess do you already have to be on your menstrual cycle to have them?
Yes.
Okay.
Yes. Typically we see them in women that are during their menstrual cycle. They tend to become less symptomatic as women get a little bit older and closer to menopause. Because when you go through menopause, your hormones start to become less and less. They stimulate the fibroids a little bit less. So these fibroids tend to get softer and shrink over time. That doesn't always occur, but they tend to. So our typical age range is anywhere from 25 to 45.
Okay.
And in regards to the other question that you had, what typically occurs if you have those symptoms? I just want to say we work in conjunction with the OBGYNs. Okay, so it really is sort of a collaborative thing. The first thing to do is to work with your OBGYN if you have one and say, okay, I'm having these symptoms. What do you think it is? And usually they will evaluate you. If they feel like it's appropriate, they will get an ultrasound. Once they get an ultrasound, they'll be able to evaluate and say, okay, the cause of this is fibroids, or it's something else. If it's fibroids, then you can take the next step.
Now you can determine, you can see them, or you can take them through the ultrasound.
Yes, the ultrasound.
Because they are growths. They are growths.
They are little growths on the uterus, the little balls that are hanging off that shouldn't be there.
Oh, wow. Wow.
So once we see that on the ultrasound, the OBGYN will say, okay, now we have options. These are the different options. And uterine fibroid embolization is one of those. Now, women that have these symptoms that don't have an OBGYN, that hear about fibroid embolization and come to us, we can start that process for you. We can do the ultrasound and we can do those things. But we will absolutely plug you into an OBGYN so that we can work in collaboration with one. Because if you're not a good candidate for this, you should absolutely pursue other things with your OBGYN. So it really is something that's collaborative.
They can come to you, but you still involve
absolutely.
an
OBGYN. Absolutely.
Which is very, so let's talk a little bit, and then Ms. Pam made it very clear that one would want to do what is best for her, whether or not she wants to have children, because, there are other factors, you want to get rid of the factors. So, like you said, childbirth is not the only reason to kind of delve into that. But let's talk about the possibility of, let's say, a 30-year-old woman, because I think back during the day now, my name ain't Dr. Habersham, but I do recall that several years ago, and I'm not really that old, but a few years ago, I see you laughing. Several years ago, it seems to me that the primary option was a hysterectomy. Whenever one had those symptoms that you mentioned, they went to the doctor, then they would go and have a hysterectomy. But I think that you're suggesting, though I understand that there's no guarantee, that maybe if you do that procedure, then it's possibility that it just doesn't totally eliminate childbirth.
That's correct. You keep your uterus, so there's the possibility of having children afterwards. That is correct.
Okay, so they should just come to you and work with an OBGYN and the decision is made. But now sometimes, do you have to go ahead, are there conditions under which, that procedure, name that procedure again?
The hysterectomy?
No.
Oh, the uterine fibroid embolization.
Uterine fibroid embolization.
Right. So uterine fibroids and embolization just means to block. So we're blocking arteries. So uterine fibroid embolization.
Okay. Oh, wow. Thank you. I might go to med school next. moving right along. So, but I'm saying that are there still instances wherein once that procedure is performed that she may still need a hysterectomy?
So women that get this procedure done very, very early on, because they keep their uterus, there is a small possibility that these fibroids can recur. So they can absolutely come back 5, 10, 15 years later. What I will say is that this is a good procedure for women that want treatment for uterine fibroids and they want symptom relief. However, because your uterus stays intact, they can recur. The only way we can guarantee that they're not going to come back is by taking the entire uterus out.
Oh, no. Yeah.
That is the only guarantee. Now, there's another procedure called myomectomy that OBGYNs do. I don't perform that procedure. That is where they go in and they take the fibroids out. Okay, and that is a very good procedure. It's a procedure where the woman's uterus stays intact, and I think it's appropriate for many, many women. Even with that procedure, because the uterus stays intact and is still in the woman's body, they can come back.
Now, when they take them out the OBGYN procedure as opposed to your procedure, do they cut it out? Is that
they do?
But with you use the.
I'm using little tools to block the arteries. Yeah. So I have a very, very small incision. It's the size of your pinky nail bed. So you're going home with the Band-Aid. Whereas with the other procedures, whether it's hysterectomy or myomectomy, it is still more invasive.
Okay. So that's more like an
it is still an operation. Right. So again, the ideal candidate for fibroid embolization is someone with symptomatic uterine fibroids that has that wants to have little downtime, doesn't want to or cannot undergo a surgery.
I see Pam shaking her head.
Yeah, I mean, most of the women that I've treated are back to work within 5 to 6 days. I don't recall, how many days were you back at work? 5 days.
Okay.
And that is certainly not the case with most major surgeries.
That's outstanding. Okay, so what if from hearing this interview, a lady, a woman, is just, maybe she has seen, some of the signs that you mentioned. What if, she wants to kind of get checked? So what should she do? So
I would recommend the next step, either talking to your OBGYN or we have a website called fibroidsgeorgia.com where you can fill out an assessment and tell us what kind of symptoms you're feeling, and we'll set up a consultation for you to come and see us at Vera, which is our clinic.
Okay, now where is Vera located?
Vera is located on Sheridan Road. It is... It's hard for me to describe exactly where it is. It's on Sheridan.
Well, give us the website. It's fibroidsgeorgia.com.
Fibroidsgeorgia.com.
Fibroidsgeorgia.com. Yeah. So they will be able to go to that website and say. But the good thing about it is that hopefully, since this is a call to action, then people who are in that situation or who, it's better to be safe than sorry, I guess. Is what I'm trying to say. So that would be a good thing for them to do. And you want to kind of look in the camera and encourage, people to kind of be concerned about it and talk a little bit about the procedure and the symptoms again.
Sure. So if you are a woman between the age of 25 and 45 or 50, and you are having the symptoms that we have described, heavy bleeding that lasts many, many days, up to 7-10 days, passing clots, urinary frequency, urgency that wakes you up in the middle of the night, constipation, or any of those symptoms, go to fibroidsgeorgia.com, fill out the assessment, get in contact with us. We will help you. If we are not a good candidate, we will work in collaboration with your OBGYN to get you the appropriate care. These are not normal things that you have to live with. These are things that should be treated.
And you do not have to have a hysterectomy.
And you do not have to have a hysterectomy. There are lots of options. We will work with you and with the team in order to get you the best treatment.
Pam, would you just like to make a comment to the audience before?
I just wanted to say that with the procedure that I had, it was a good choice for me. Like Dr. Patel stated, it's not that I was interested in having any more kids, it's just that you feel like this is my body, so I want to keep exactly what I came with. So it's something that I decided. I was glad that I was introduced to him to get this procedure done. It's made my life much better, because before it's just that having those heavy menstrual cycles, it's like it takes away from your life at some point, because it's discomforting. So I think it's something that you should consider if you're going through it, to look into it, to get the procedure done.
Again, Ms. Pamela, I want to thank you very much. You didn't have to do this, and your interest in helping somebody and informing somebody is just very noble on your part. So I'm going to shake your hand and thank you for doing it. Doc, I appreciate your explanation of the procedure, and I encourage everybody, as a part of this presentation, there will be some supplemental video that will be added that will help to further explain the process, and even with the right address on it and things of that nature. This is a call to action.
A call to action.
I'm your host, Alex Habersham, having interviewed Mrs. Pamela Brown, who was a patient and is a patient of Dr. Tariq Batel. And this has been a very, very informative interview, and I really appreciate your comment. This is a call to action.
A call to action.
I'm your host, Alex Habersham. Have a great day.
If you suffer from uterine fibroids, you should ask your OBGYN if you're a candidate for uterine fibroid embolization. A good candidate for uterine fibroid embolization is a patient that has symptoms such as abnormal uterine bleeding or bleeding between menstrual cycles, as well as symptoms such as urinary frequency or constipation due to uterine fibroids. Uterine fibroid embolization is a minimally invasive procedure where we block the arteries around the uterus leading to the fibroids. When we block these arteries, the uterine fibroid shrinks over time. The benefits of uterine fibroid embolization include a high success rate as well as a quick recovery time. We have the ability to perform this procedure in the outpatient setting. Furthermore, the patients preserve their uterus, thereby possibly improving their fertility. The recovery time is about 2 to 3 days of vague abdominal and pelvic pain, which is typically very well tolerated by patients. Most of our patients are back to work in about 3 to 5 days.
I was a little nervous, but he pretty much explained to me that it wasn't a major surgery and how simple it would be. He really walked me through, gave me pamphlet to look at, to actually read through it and see everything that would take place. When I got to the hospital for the procedure, it was really simple. They gave me some medicine for the numbness. There was a puncture, like a heart pinch, and during the procedure I was woke, and I never knew anything was actually happening other than I knew he was moving around. He was trying to tell me, pretty much what he was doing throughout the procedure. After the procedure, I had cramps, but other than that, it was really easy. A 3-day downtime pretty much for me. I know that they tell you it can be up to 7 days, but 3 days is great, versus a 6-week downtime with a hysterectomy. So that I feel like is a great thing for any woman, that you don't want to be down when you have kids in the house and you want to be able to get up and do what you need to do.
My philosophy for patient care is really teamwork between myself, the patient and their family, the patient's primary care physician, as well as the staff here at Vera. It's really a team effort that helps provide for the best patient care, ultimately. I truly believe that.
I would definitely recommend Dr. Patel. I already have to one of my coworkers.